Hello, this short lecture is on angina. It's something that you've probably all seen in clinical practice. It should highlight the key areas of interest and provide you with a working knowledge of angina for your clinical practice. We will look at, in this lecture, we will look at some definitions, look at different classifications and types of angina, look at the pathophysiology associated with it, clinical diagnosis and management. So if we look at a definition, it's often referred to in the literature as angina pectoris, which talks about, which really, if we look at the definition of that, or it really means pain in the chest, and it results from an imbalance between supply and demand to the myocardium, or oxygen demand to the myocardium. It has a common presenting symptom, which is typically chest pain, although a lot of the literature would suggest that it's more of a discomfort than pain. Most commonly caused by narrowing and hardening of the arterial walls, caused by atherosclerosis. However, there is some other causes which we will discuss, which include spasm of the normal coronary arteries, and arteritis can also cause this angina type pain. Where we have increased demand for the myocardium, for instance in thyrotoxicosis and during periods of stress, then there is also a possibility of this pain that patients experience. And also in aortic stenosis, where the heart has to increase its workload to maintain adequate output, will also result in an imbalance, which is this underlying cause. Types of angina, there's a number of different types. If we think from our own experiences, then there's the stable angina, defined when it is not a new symptom and where there is no change in frequency or severity of attacks. And it's fairly predictable, and it's when the heart has to work harder. So we'll know of patients who take GTN spray prior to climbing a flight of stairs or walking up the hill to their house. So the frequency and severity of attacks is fairly predictable and therefore relatively straightforward to manage. On the contrary, we have unstable angina. This is a sort of deterioration in previous stable angina, with symptoms now recurring at rest. This should be treated as an emergency when patients start to experience chest pain at rest, and these patients certainly have an increased risk of myocardial infarction or cardiac arrest. Refractory angina, this is the real challenge for the clinician, and this refers to severe cases with advanced coronary disease where revascularization is not possible and pharmacological management is ineffective. It's interesting to note, though, however, the mortality rates for this group are no greater than any of the others. However, the major problem here is the impaired quality of life that these patients experience. Finally, we've got the variant or Prinzmetal angina, occurs with no provocation and at rest, and is a result of arterial spasm. And it appears to be more common in females and can be a response to cold. And also the literature sometimes discusses the possibility of it occurring more frequently in the morning. So we said that the main cause of this imbalance that we've discussed is this atherosclerotic lesion. And these lesions are a response to injury, a response to damage to the endothelium and the build-up of a atherosclerotic plaque. And this obviously reduces the cross-sectional area of the artery in question. These plaques can build up either eccentrically or concentrically, and this is quite key with regards to management of angina. The eccentric lesions is where we get in a build-up of plaque on just one area of the endothelium, and there's part of the arterial wall is free from lesion. This unaffected segment can undergo spasm and cause significant alteration in the cross-sectional area of the lumen. In addition, the normal or the area free of lesion will also respond to nitrates and the vasodilatory effects of that, and therefore in eccentric lesions, or where eccentric lesions are the cause of the reduced flow, then GTN management is effective. On the contrary, if we think about concentric plaques, whereby the plaque builds up across the whole lumen, then you have no alteration in cross-section area is possible. So there's no free area of the arterial wall for the nitrates to work on, and therefore pharmacological management is more difficult. Diagnosis. Well, diagnosis of angina is primarily based on the clinical history. Most patients with angina report of retrosternal chest discomfort rather than actual pain. Usually described as pressure, heaviness, squeezing, burning, or a choking sensation. Angina pain may be localized primarily in the epigastrium, back, neck, jaw, or shoulders, and typical locations for radiations of pain are in the arms, shoulder, and neck. Typically, when we're gathering a history from these patients, angina is predicted by what is sometimes referred to as the 4 E's. So normally results from exertion, whether that's an increase in some sort of physical activity. Eating, often after eating a large meal, then sometimes patients will experience this chest pain as blood flow is redirected towards the gastrointestinal tract. Exposure to cold or emotional stress can also bring on an increased demand for the myocardium. With regards to emotional stress, that idea of the fight or flight and the increase in the force and rate of contraction associated with that. The report lasts for approximately 1 to 5 pain or discomfort lasts for approximately 1 to 5 minutes and is relieved by rest or glycerol trinitrate or GTN spray. Chest pain lasting only a few seconds is not usually anginal pain. The intensity of angina does not change with respiration, cough, or change in position. And pain above the mandible and below the epigastrium is rarely anginal in nature. Patients, when you're taking a medical history, should be asked about the frequency of angina, the severity of the pain, and the number of the nitroglycerine tablets or number of use sprayed during angina episodes. So primarily, a lot of the diagnosis will be based on the medical history. We do have to be mindful that there is lots of other reasons for chest pain, and that needs to be that should also form part of your medical history taken. Investigation. NICE guidelines identify 3 common features of angina pain. One is this idea of constricting discomfort in the front of the chest or in the neck, shoulder, jaws or arms. And this tends to be precipitated by physical exertion and relieved by rest or GTN within 5 minutes. So they're the 3 common features of anginal pain that the NICE guidelines have identified. This allows them then to classify them or characterize them into typical, atypical or non-angina pain. So what NICE suggests is that if your patient presents with all 3 of those signs, then it's classed as typical angina. If they've only got 2 of the 3, then they define it as atypical. And if they only present with 1 or none, then they consider that to be non-anginal chest pain. So this diagram here shows the typical angina pain areas. We can see that area at the centre of the chest, the epigastrium area. It can radiate up into the jaw and down into the upper abdomen. And the shoulders and the arms as well can also be affected by this imbalance and this lack of oxygen being supplied to the myocardium. The Canadian, there's a number of classification systems. The one that's commonly mentioned in the literature is the Canadian Cardiovascular Society Functional Classification of Angina, or the CCS Angina Grading Scale. I think it was developed back in the 70s, but it's still mentioned quite regularly in the literature. And the idea was of this was to be able to use a classification system which was used to assess the severity of the patient's angina. It doesn't, the classifications don't define a therapy, or are not defined to a therapy guideline for each class, but it does give medical practitioners a sense of the severity of the angina and the therapies that would be available for each one. But it's not, there's no actual direct links with class and therapy as such. If we look then, class 1 is no angina with ordinary activity, but angina with strenuous activity. So that's really your mild, stable angina, whereby patients may experience some pain and discomfort when climbing stairs or doing some strenuous physical activity, but normal day-to-day walking and moving around, then they're not really experiencing any great deal of pain or discomfort. Class 2, angina during normal activity, walking up hills or rapidly upstairs, and mild limitation of activities. This is starting to affect now the quality of life. So running up the stairs, walking up hills, we're now starting to see some discomfort and pain when doing those activities, and therefore we're starting to see some limitation of activity with our patients. Class 3, angina with low levels of activity, so walking 50 to 100 metres on the flat, and this is now marked restriction of activity. And class 4 is angina at rest or with any level of activity, and then we're starting to think with regards to class 4 whether we're now starting to consider this as an unstable angina and the severity that brings with it. Assessing and diagnosing suspected stable angina. This algorithm was lifted from NICE guideline CG126, which there is a link on the hub site for this, and this actually guideline is interactive when you click on it on the NICE website. So if we look at this algorithm, you've got person with suspected stable angina, clinical history and physical examination. So we've also talked about what types of activity caused the pain, thinking about assessing the typicality of that chest pain. So chest pain related to activity responds to GTN spray or a sublingual tablet. If it is typical or atypical angina, then we look at initial management and an ECG. Other diagnostic investigations, then confirm the diagnosis of stable angina or continue with investigations, and then we will manage stable angina. We'll talk a little bit about that as we go on through the next slides. So if you want to go onto the website of NICE guidelines CG126, when you click on each one of these, then it will give you an explanation for each, but I'll try and break down some of that in the following slides. Initial management and ECG. NICE guidelines suggest the following: blood tests to identify conditions which may exacerbate the symptoms of angina, so anemia. So again, if you've got low oxygen levels within the blood caused by anemia, then we are not be able to supply sufficient oxygen to the myocardium. If we've also got associated atherosclerosis, then this will compound the problem. They will talk about consider aspirin after excluding any contraindications. Remember, aspirin is, in the case of cardiovascular disease, is used as an antiplatelet drug, and when we look at the the cardiovascular pathology lecture. Then we've talked about the response to injury hypothesis, and that the initial factor in the development of a plaque is damage to the endothelium, and then the platelet aggregation that follows that. Aspirin, often our patients are given 75 milligrams of soluble aspirin. That is to try and reduce that platelet aggregation, which is the initiating factor in the development of atherosclerosis. ECG, electrocardiographs, then patients could have a normal resting 12-lead ECG. Although the resting EGC could be normal, some changes associated with coronary artery disease may be present and may indicate a previous infarction or ischemia, and that could include pathological Q wave, ST segment and T wave abnormalities. Remember, the ST segment represents the interval between the ventricular depolarization and repolarization, and should be isometric in waveform, and any elevation or depression is identified as some sort of pathology. Further diagnostic investigations, well, first line, CT angiography. Second line is stress echocardiogram. So that's imaging of the myocardium at rest and then immediately after exercise. And this should show areas of dysfunction secondary to ischemia, show any valve disorders, and any left ventricular hypertrophy. And the third line would be coronary angiography. Management of stable angina. Well, as ever, we're talking about providing a patient with this patient, or that should be provided patient-centered care. So we should be looking at providing information, identifying to patients what angina is. Lifestyle modifications, therefore trying to lose weight, reduce blood pressure, stop smoking, reducing alcohol intake. All these things should be attempted in with regards to the underlying cardiovascular disease. Obviously thinking about diet and reducing saturated fats, all those things which may contribute to cardiovascular disease. Short-acting nitrates, we've talked about GTN spray or tablet, and that would cause, what that does is cause vasodilation. In addition to vasodilation of the coronary arteries, it also causes vasodilation of the venous system, and therefore increases the capacitance of the venous system and reduces preload on the heart. And if we think about Starling's law of the heart, reducing that preload will reduce force and rate of contraction and the demand of the myocardium. If we think now about other medication that these patients may be put on, they may be put on a beta blocker or a calcium channel blocker. And a beta blocker, as we know, would block beta adrenal receptors, and what that would do would be to reduce the force and rate of contraction of the myocardium, therefore reducing oxygen demand. Main problem with that is the fatigue and tiredness that patients sometimes experience. Calcium channel blockers again reduce calcium influx into the myocardium and therefore reduce force of contraction. If either of those are not tolerated, then the idea would be to switch. So if your patient can't tolerate beta blockers, then you would put them onto a calcium channel blocker, and vice versa. If you put them onto a beta blocker, you should also put them onto dihydropyridine. If they're not tolerated or contraindicated on either of those, then you would look at using a long-acting nitrate. If you've got symptomatic on the two anti-anginals, so your patient doesn't tolerate the beta blocker or the calcium channel blocker, then you would think about percutaneous coronary intervention or coronary artery bypass grafting, and there's some guidelines there provided by NICE. So lifestyle, short-acting nitrates as short-term prevention or prophylactic prevention of the anginal pain. Either a beta blocker or calcium channel blocker. Which one, if they don't tolerate one, then try the other. If that doesn't work, then try both. And then if there's a problem with that, then you would consider at that stage revascularization with either percutaneous coronary intervention or a bypass graft. Unstable angina, this is where we're now starting to see pain at rest. It's fairly unpredictable, and this is considered an acute coronary syndrome along with myocardial infarction and the non-ST elevated myocardial infarction and ST elevated myocardial infarctions. The underlying pathological process here is that the rupture of an atherosclerotic plaque and thrombus formation, and this results in a rapid reduction in the cross-sectional area of the lumen. This can also precede a myocardial infarction, or if we get a rupture of an atherosclerotic plaque which causes total occlusion, then we would be considering this as a myocardial infarction. So unstable angina is in some ways be treated as a medical emergency and would require assessment in a coronary care unit. Diagnosis: patients with unstable angina may complain of onset of chest pain at rest, deterioration of pre-existing angina, so they've been fairly stable for a while, fairly predictable course of angina pain, and then suddenly they're starting to experience more frequency of it, and chest pain at rest. Atypical patients can present with indigestion and breathlessness also. Diagnosis here, again ECG, 12-lead ECG, again it can be normal, however we can see ST depression and T-wave inversion can also be seen. We're now starting to think about biochemical markers, and troponin T, which is very specific and is elevated with damage to the myocardium, can be slightly raised in unstable angina, but again that can also be fairly normal. Early management of unstable angina, so you've got patient experiencing chest pain at rest, they admit to coronary care unit. Important to know that if the thrombus causes complete occlusion, this will then be escalated to a myocardial infarction. Normally given aspirin, 300 milligrams of a loading dose. In cases of hypersensitivity to aspirin or allergy to aspirin, then the use of clopidogrel or as an alternative antiplatelet drug. Antithrombin therapy, NICE recommend fondaparinux in those who do not have a high bleeding risk, but it's not to be used in patients with a planned angiography within 24 hours. As an alternative, we can use low molecular weight heparins such as dalteparin. Also administer ticagrelor, which is another antiplatelet drug, and consider revascularization using percutaneous coronary intervention or coronary artery bypass grafting. That finishes or completes the overview of angina. It's a common clinical condition that we see in practice, both in routine practice, but you might also have patients presenting for surgery who have a history of angina, and it's important that you gather a comprehensive medical history and establish the nature of the angina and when they experience it. Thank you.